Okay, are we seeing this okay? Yeah, okay, that's perfect. So hi everyone today. I'll introduce myself in a moment, but I want to say thanks for allowing me to be here. It's a passion of mine to share some of the stuff that we're doing, and I'm so thankful that Carolyn's joining on this conversation as well. Um, We'll introduce ourselves in a moment, but we'll be talking about partnership in stroke rehabilitation research in this collaborative conversation. So Brenda gave a lovely land acknowledgement for where she is, but I'll let everybody know that I'm in British Columbia right now doing my postdoctoral fellowship at UBC Okanagan, which is on the unceded territory of the Syilx Okanagan peoples. And for those of you who aren't familiar with the Syilx Okanagan people, it encompasses 35 Indigenous reserves stretching from the south of Kamloops all the way to Washington in the United States. So this landmass is absolutely massive. And this was something really interesting that I learned when doing some research about them. Also important is that as of 2017, only 50 elders speak their language. And this is really, really important to highlight because it kind of highlights the work that needs to be done for decolonization across Canada, really. Pardon my voice here. Um, and so those are just some things that I learned about the Syilx Okanagan people in my time here. So happy to share that. So I'll pass it to Carolyn to just introduce herself and where she's from, and then I'll introduce myself. Go ahead.
Hi, my name is Carolyn Pinelli. I live in Stoney Creek, the east end of Hamilton.
Nice.
And
Yeah,
I've worked with Kenny for a long time.
yeah, a long time. We've been working on several projects, and Carolyn will get into how we've worked together and in what capacity towards the end of today's talk. My name's Kenny. You've probably seen my face a couple of times through these email pushes for today's event. I'm a postdoctoral research fellow at the University of British Columbia Okanagan campus, doing research, continuing my research on people with stroke, but also expanding to people with physical disabilities and how to promote exercise and physical activity participation for those individuals. So without further ado, I'll get into this talk. And so thanks, Allison, for putting the link to the paper in the chat. It'll be the focus of today's conversation is our recently published paper in the British Journal of Sports Medicine about strength training in people with stroke. And really important to this work was the key contributions from our advisory group. So that'll be really the focus of today. I'll give a little bit about what we found in the paper, but really about the methods that we used for partnership. So just to give a brief background on stroke, it's the leading cause of neurological disability in the world, and quite a few new strokes happen each year here in Canada. After a stroke, there's a loss of physical function that is highly common. Up to 60% of people experience weakness or coordination issues after their stroke, which can then limit their ability sometimes to participate in physical activity and exercise programs. This can then result in a higher risk for a recurrent stroke, which is called the cycle of detraining post-stroke, where these impairments can lead to activity limitations, which can then cycle and cycle and cycle. This is a term coined by David Saunders in 2014, the cycle of detraining. Now, luckily, we're all interested in how we can break this cycle, and strength training has been recognized as one way to do it. The current guidelines recommend that people with stroke participate in physical activity and exercise, but specifically strength training can hold potential for making a difference for stroke recovery. The guidelines recommend doing strength training 2 to 3 times per week at 50 to 80% of 1 repetition maximum intensity, so a moderate intensity of exercise, for 1 to 3 sets of 10 to 15 repetitions for all the major muscle groups. Now, these are quite broad ranges and sometimes not super helpful for people with stroke, but this is mainly because there's a lack of evidence in people with stroke. This is taken directly from people with heart conditions and other cardiovascular diseases, not specifically to people with stroke. And so there's a need for more research on strength training in people with stroke to help better inform the guidelines. But the question remains, does strength training actually improve daily function? Well, there's mixed reviews on that. So other studies have found that strength training has very large effects on muscle strength outcomes, yet they have rather inconsistent effects on physical function. And apologies as my dog barks. I think my wife just came home. Rather inconsistent effects on physical function. But there were some limitations to these earlier reviews that maybe we should consider in light of these results. Namely, they had restrictions in who they were and what studies they were including in these papers. They had biases in how they selected their outcome measures. And they didn't consider the potential for differences amongst patients or differences amongst the interventions. As we know, strength training can look very different for different people, and they didn't consider that in their analysis. But most importantly, and one thing that I'll be focusing on today, is the lack of partners with lived experience in the reviews. Now, this isn't a unique issue to strength training. In people with stroke, 26% of systematic reviews published between 2015 and 2019 in the British Medical Journal involved patients or the public. Now, this number seems kind of high, right, for those of you who have been doing this work for a long time. But it's important to note that the British Medical Journal requires that you describe your patient and public involvement. And before they made this a requirement, less than 1% of systematic reviews published in this journal actually did patient and public engagement. So really uncommon in systematic reviews to actually include the perspectives of people with lived experience. And in fact, no review on strength training post-stroke involved people with lived experience. And so this was the gap that we were trying to fill. So of course, we were interested in examining the effects of strength training on patient-important stroke recovery outcomes, but we made sure that they were informed by an advisory group of community members with lived experience. So just an overview of our systematic review methods. It was pretty straightforward. We searched through 8 databases, 2 clinical trial registries, and did some hand searching for articles that were randomized control trials in adults with stroke or transient ischemic attack, which is also termed a mini stroke. The intervention consisted of strength training without a co-intervention compared to no exercise or usual care. And the outcomes were defined by our advisory group. And so I'll get into what this actually means in a moment. So our partnership methods, we consulted the ACTIVE framework. This was a framework made by Pollock and colleagues in, I believe, 2019, which identifies key areas that partners can engage in systematic reviews, particularly in planning the review, conducting the review, and interpreting and disseminating the review. And they identify specific areas. So this framework was lovely because it really highlighted the key areas that partners can help. They identified 12 areas. So in planning the review, developing the research question, planning the methods, writing and publishing the protocol. In conducting the review, partners can help develop the search strategy. They can help run the search strategy, select studies, collect the data, assess the risk of bias of the studies, and analyze the data. And then what's most commonly done is in the patient and public involvement world is helping interpret and disseminate the review by interpreting the findings, helping writing and publishing the review, and helping with dissemination and impact of the review. So these are the 12 key areas termed the 12 stages of opportunity for partnered involvement in reviews. Now, this is done, taking it a step further in depth, it's done at 5 different levels of involvement that kind of form this hierarchy of how people can be engaged in systematic reviews. Namely, starting from the bottom, receiving, contributing, influencing, controlling, and leading the systematic review. Receiving involves simply receiving information about the review or the results of the review. So this could be like sharing the report with your partners and discussing the results. Contributing really means providing views, thoughts, or feedback or opinions about the systematic review. So this is commonly done through interviews or through focus groups. Most commonly, these partners are actually research participants that kind of help steer the directions. Next is influencing. And so this gets a little more involved, where this primarily consists of stating, commenting, advising, ranking, voting, prioritizing, but without direct control over what decisions are being made. So they can help inform some of these things, but they may or may not be implemented in the review. The next level of hierarchy here is controlling. So this is really about making decisions or controlling one or more aspects of the review in collaboration or under the guidance with the review authors. And then probably the pinnacle of this, which is why it's at the top of the pyramid, is leading the review. And so this could involve partners developing the research question, having a lead responsibility in certain aspects of the review, ultimately resulting in authorship or making decisions about the methods and how the systematic review is actually done. And so for our purpose, for our systematic review, we aim to provide an opportunity to the partners to contribute in any of these levels, whatever they felt most comfortable with, across each of the 12 stages of or many of the 12 stages of opportunity. So we consulted the active framework to make some of these decisions. But as we know, as trainees, things move fast and things change a lot. And so we obtained funding from the collaborative in 2023 after the review had started. So we were already deep into running the search strategy and kind of already doing the review. And so we had to retroactively look at ways in which our partners could be involved at that stage already. And so we identified 7 areas that were actually really crucial to this. Our partners helped refine and develop our research question a little further. Our partners helped plan the research methods. Our partners helped collect the data from the study, so data extraction. They helped us analyze the data, and then all of our knowledge dissemination strategies, they helped us with that. So this was really great. And we ended up with 6 partners with lived experience that helped inform these strategies. Carolyn was a key contributor to this. So how did we do this? So after we found our partners from the community, we wanted to really set up partnership expectations. And this really helped generate some clarity amongst everybody involved and make sure that everybody was aware of what was going on and why they were here and ways they can meaningfully contribute to the research. So we co-developed 10 principles of partnership based on the collaborative's philosophy of collaboration, but also the IKT guiding principles by Gainforth and colleagues. And of course, I'm happy to share any of the papers that I put up later on with Allison so she can distribute. But we developed these guiding principles together with the partners. I had mentioned that we had 7 areas in which the partners contributed to, but we kind of framed this into 4 main opportunities or themes that the partners could collaborate on. And we also ensured that the partners knew we were taking notes and providing the meeting summaries after the meetings by email, so that everybody is on the same page after each meeting. Now, speaking of the meetings, this was step 2, how we actually conducted the review. So this was done across 4 meetings, and I'll get into depth a little bit later about what those meetings actually consisted of. But at a very high level, meeting 1 focused on defining stroke recovery. Meeting 2 was about data extraction plans. Meeting 3 was about interpreting our results. And meeting 4 was about identifying the research gaps and knowledge translation opportunities. And important to note that all these meetings were conducted online using Zoom. Originally in my application, this kind of speaks to how research changes all the time and plans change. The partners were actually from different provinces and different locations across Ontario. We had some partners in Stony Creek, like Carolyn, but we also had one partner in British Columbia. We had one partner in Guelph, one partner in St. Catharines. And so everybody was kind of quite far ranging. And so we adapted and pivoted a little bit to use Zoom instead of these in-person meetings like we had planned in the budget. Okay, going into meeting number 1, defining stroke recovery. Now, this wasn't the only goal. We had 4 goals for this specific meeting. The first one was the team introductions. We wanted to make sure that everybody got to know each other and introduce each other to really understand and become comfortable with each other throughout this process, because it was quite long. It was about a 6-month process. So we wanted to make sure everybody was comfortable with each other. We also gave another overview of the project. We originally gave a guiding document that highlighted this, but we wanted an opportunity for the partners to ask questions in further depth by giving a project overview during this meeting. We also identified the roles, responsibilities, and expectations. These were the 10 guiding principles that we co-developed. And then we asked, putting in a little text box, is there anything that's missing from these? And we adapted and adjusted our wording for the partnership principles for what mattered to our partners here. And then finally, as the meeting title suggests, we defined stroke recovery. That was our main step that kind of steered the entire process. So we asked participants to share their stories about stroke. It wasn't just didactic where we would have a question and answer. We gave an opportunity for everybody to share their story so that we could have a comprehensive view of what stroke recovery means to everybody. Myself and my supervisor, Dr. Ada Tang, we together wrote a preliminary definition of stroke recovery based on our discussions and our shared stories. And from this, we shared it with the partnership group, and members added and edited the definition as they saw fit via email. And the definition that we ended up coming up with was actually quite nice. And we used this for the entire review process and kept it in mind. Our definition was regaining function and adapting to one's current capabilities with a goal to participate in activities that are personally meaningful. I thought this was really impactful and honestly quite comprehensive to what we're trying to accomplish with the review. So I was really, really happy with how this came out. Meeting number 2 was data extraction plans. And so what I mean by this is we, as the researchers, we sometimes make assumptions about what data needs to be extracted from individual papers when doing a systematic review. But we wanted to put this in the hands of our partners for them to decide what we need to be talking about in our review. And so we asked participants 2 main questions. Firstly, what participant or study characteristics are important to know? What do you need to know about these studies? And secondly, which outcomes fit the definition of stroke recovery that we had generated together? And what I mean by this second question is we collected and compiled an entire group of outcomes that were measured in these studies and presented it to our advisory group. We used the grade rating of importance scale, which is this scale that I've shown here, which rates outcomes from a scale of 1 to 9, with 9 representing an outcome that is critical for decision making and 1 being of low importance. And so we asked our partners to rate how they felt about specific outcomes. So for example, we asked, how do you feel about balance in terms of stroke recovery? How important is balance to you? And they gave us a rating from 1 to 9. And we only included outcomes that were rated as important, but not critical, at least important, but not critical for decision-making, but also critical for decision-making. So that was meeting number 2. Meeting number 3 was interpreting the results. So on our end, from the research team's end, we conducted the meta-analysis and had results to share. We showed the effects and provided education about how to interpret these effects. And this is a figure that was directly taken from the report that we shared with our partners, where we presented what a standardized mean difference is. And we provided definitions as well earlier on in the document, and how to interpret those effects. But also when available, when we did a mean difference, for example, for habitual walking speed, we provided definitions of what that actually meant. So for example, a change of less than 0 indicates a no change or statistical decrease in walking speed. Between 0.01 and 0.1 is sort of a statistical increase, but may not be meaningful. And then finally, a clinically important increase in walking speed is something greater than 0.1 meters per second. And so we made sure to provide these definitions and provide education about how it should be interpreted. And based on how we interpret the results, our partners reconsidered the importance of our findings. And so for each of these outcomes, they re-rated the importance of, whether it was a large effect or a small effect, using the grade scale once again. And this was a question that we asked them specifically. What would I want my physiotherapist or doctor to know about strength training? If it improves strength, do we want our physiotherapist to know that it improves strength? Does it improve walking? Do we want our physiotherapist or doctor to know that it improves walking? And so we asked them to, again, rate our findings on this scale. And this was really important because it went directly into our certainty of evidence table. So as you can see here, here's our, at least a part of our table. And on the far right-hand side, we have the importance rankings. And so our outcomes were listed in order of importance that were rated exclusively by our advisory group, which rated from critical, which you can see walking capacity is rated as critical, scoring a 9, but also provided the range of responses and scoring. And so finally, we arrived at meeting number 4, identifying the gaps and knowledge translation. So we presented a summary of the study's results, which was really promising, but also 6 main gaps that we identified in the literature. And we presented this table. Again, this is directly taken from a guiding document that we sent out before the meetings. And we asked the partners 3 main questions. Firstly, why is this gap important to people with stroke? And you can see in the table, sorry, I should direct you to that. The potential gap is on the far right of the table. And we asked, why is the gap important to people with stroke? Do you think that this might impact the message that we're delivering when we consider these gaps? And third, do you think that clinicians, physios, doctors, for example, should be aware of these gaps? And we had a really, really nice discussion about these, and we figured out which gaps needed to be included in the review to talk about. The partners also provided feedback on our infographic, which I'll show in a moment, but also places to share our research, different community groups that they're involved with, different presentation opportunities that might exist. And so they provided some feedback about how we can best disseminate our knowledge. Okay, so what did we find? These slides will be rather short because I don't want to focus too much on the effects of the intervention, but we sifted through about 9,000 titles and abstracts and included 42 different randomized trials. This included about 2,200 participants between the ages of 49 and 78 years old, and about 40% were female. Here's the infographic that we co-developed with our partners, and they gave us some really, really good feedback about this. We found that strength training enhances stroke recovery compared to usual care or no exercise at all. And it improves functional ability and mobility. I'm sort of going from the top to the right. It improves habitual walking speed. It improves fast-paced walking speed. It improves balance. It increases walking capacity, lower body strength, and improves the ability to perform activities of daily living. And so this infographic we presented to our partners, or at least the original one, and they provided some really insightful feedback about how we should edit this infographic. That would make most sense. And this infographic will be published as well in the British Journal of Sports Medicine blog, which we've been invited to write a blog post about, featuring another one of our partners who's co-writing it with us. Now, this is really interesting and something that I'm really, really passionate about, both for the direction of this research, but also for the direction of my research program, hopefully down the line, if I ever get a faculty position. But here are the gaps in literature that we found here. Mainly, we identified 3 outcomes that were deemed critical for decision-making by our partners, but only 4 studies had measured these outcomes. This is a massive gap because it means that strength training trials are not always measuring what is important to patients. This is something that we need to do ahead of time, and we need to readjust how we're going about this. We also found that 70% of studies excluded people with aphasia or cognitive challenges. This was really striking to us because aphasia and cognitive challenges don't necessarily impact people's ability to exercise. So why they were doing this was a little bit striking to us. Most studies were also conducted in older adults with mild to moderate stroke. And so they were missing a key demographic of this population. So our main takeaways here were that strength training trials were not always inclusive of people with other forms of disability, of younger people with stroke, and of people with more severe strokes as well. So going into the future directions and the needs for stroke rehabilitation, and also for me, in the context of stroke rehab research, we need more diversity in our recruitment practices. As I mentioned, some studies were excluding people and not necessarily providing reasons for why they were excluding those individuals. And so we need to do a little bit better for our recruitment practices. And secondly, and this is arguably most important for me, is that the studies weren't necessarily measuring outcomes that are important for decision making. There were, as we went down the list of the so-called critical for decision making outcomes, not many studies actually measured them. There were a couple of studies that were rated as important that only were measured in 1 or 2 studies as well. So this is a key area that we need to do a little bit better on. In terms of my own research, I really want to make sure that end users, more broadly, so including clinicians as well, but especially people with lived experience, are involved in the research process, and they are essential for this research. My goal is to integrate partnership as a core component of my research program in the future, and this is something that I will not budge from. This is something that I have learned through this process to be so valuable for everybody involved that I really need it to be part of my program. So just ending off here, I'm really, really thankful for getting the support from the collaborative, but it's not just the money. Really, it's not just the money to fund what we did, it's the support all along the way. So from the larger collaborative team, but also their partners. I was sharing with everybody before the call that I had met the collaborative's partners ahead of time before starting my research to really talk through my plans, and they gave me really insightful feedback, and so I was really, really happy to share that. The collaborative provides such a strong platform for dissemination and amplifying trainee voices. This is really important because we know research can move slowly and moving things to publication can also move very slowly. And so the collaborative provides so many opportunities for us to share our research. And that was really important for me. And honestly, conversations like today and presentations like today are super, super important for that. And of course, I can't emphasize this enough. Support from Sue. Sue is an incredible leader and just an incredible person all around. And none of this work could have been possible without her. And of the many things that she's helped me with, I'll list just a couple just to show. She held regular touchpoint meetings with all the trainees. She held touchpoint meetings with everybody, but also provided a safe space for people to feel like they could engage independently, one-on-one with Sue, to kind of pick her brain about things. She created a really collaborative working environment with the trainees. And I know these are kind of buzzwords about what things can or what impact things can have, but really she fostered a really good working environment with the other trainees that helped us network with people. I mean, a lot of the times they were in my program in the School of Rehab Sciences. But just to share experiences. We don't do things in isolation or in silos in research. We need to learn from each other to do better. And she also provided opportunities for leadership. This was really important. We got to chat with the next cohort of trainees who got the award, and provide insights into what we did and strategies to kind of mitigate some of the issues we were having. I know sometimes like recruitment can be an issue, but we navigated these conversations together. So I thought that was really great. So thank you, Sue. I'll also acknowledge the rest of the advisory group here before I pass things off to Carolyn to share some stories. I'll also acknowledge the co-authors on the paper at large. And again, of course, the collaborative for supporting this work. Eternally grateful for this. So I'll pass it off to Carolyn, and I'll keep my slides up because Carolyn has sent me some pictures to go along with her story. So, feel free to pin Carolyn or pin the pictures, whatever you'd like to do. But as Carolyn goes through, I'll just click through and I'll mute myself because you've heard enough of me. All right, go ahead.
Okay, so my name is, can you guys hear me? Okay, my name is Carolyn Pinelli, and as many of you believe, stroke only happens to people, only happens to the elderly, and I'm here to say that's not the case. On April 29th of 2017, I woke up feeling great. I took my son to school and ran a few errands. When I got home, I had double vision in one of my eyes. Soon I had double vision in both eyes, and I knew it was time to go to the hospital. That afternoon, I was admitted to the stroke ward for observation for the weekend. On the Sunday night, my mom noticed the right side of my face was drooping. So I was rushed to the operating room and to retrieve a blood clot from my brain because I was suffering my second stroke. As I was recovering, the doctors discovered I had vegetation growing on my heart valve, which is called Lipman Sachs. It's a rare side effect of my lupus. I spent 8 weeks in the ICU with a breathing tube and a trach in my neck. My son was only 6 years old at the time, and my family thought it would be too frightening for him to see me unresponsive and hooked up to all the monitors and IV. So he did not visit me during that time. Once my condition had stabilized, I was transferred back to the stroke ward for assessment, and the team of doctors felt I would benefit from my time at St. Peter's. St. Peter's is known best for its palliative care ward dedicated to seniors, but most people do not know they have an excellent rehab program. When I first arrived at St. Peter's, My main form of communication was nodding and blinking. I had to work on rolling over in my bed and was fed by a tube. The dietitian worked very hard to find tube food that agreed with me because she knew how badly I wanted the tube to be removed. I can appreciate her hearing how hard it was for me to want every day to want that tube out. But her and the speech therapist worked together for a diet that balanced my nutrition and swallowing needs. They also collaborated to help improve my speech. In the gym, my team of physiotherapists developed a program for me. When I first arrived, I couldn't stand or walk. They had me do sit stands, which is my least favorite thing, and Kenny knows that. They had me walk between bars, use a walker, walking stick, and climb the stairs and car transfers. They trained my brother and my husband to help me walk so I could get extra practice. I also attended a balance class where I learned how to make a bed for using that method I still use today. I would often show up at the gym without a scheduled time because I had a McMaster student, Kendra, who would work with me, and she was great. After a few months, I mastered the stairs, and the physiotherapist asked me to do a workshop for the McMaster kinesiology students. Occupational therapy was also a very important part of my recovery. The team of therapists taught me how to transfer from my bed to a wheelchair, sit up on the side of my bed without assistance. Once I mastered all these, they taught me tasks like dressing myself, taking showers, basic grooming tasks, and cooking simple things. They also took me shopping, which I love to do. They taught me how to do my makeup. I was challenged to do things I was letting my family do for me. This newfound independence gave me a great boost in my self-confidence. They also spoke to me about the assisted devices like extra railings, a shower chair that I would need once I was discharged. The social worker also played a big part in helping me keep a positive attitude. We would meet once a week for mindfulness classes that really helped me live in the moment and not get upset at the things I could not control. She was great, helped with my family, filling out the forms I needed during my 4-month stay. When I finally returned home in October 2017, I was sent to the outpatient rehab at the General, where I spent 8 weeks building on my strength and attending occupational therapy classes. During these classes, I did activities that helped me get my driver's license back. I also graduated, from there I graduated to the Fit for Function class at the Y, where I worked out 3 times a week for 3 months. During those workouts, I would walk on the track for 10 minutes and do a variety of exercises using yoga balls, pylons, and steppers. These exercises helped me gain even more movement. Through Fit for Function is where I met Ada and her team. They invited me to be part of the studies at McMaster. Today I get my daily exercises from walking my dog and playing sports with my son, who is now 14. Since last year, I've been participating in the power study at McMaster 3 times a week. It includes high intensity strength training for both upper and lower body. Being in the power study has really increased my confidence in my physical abilities. The trainers motivated me to push myself further than I thought possible, especially during exercises I found difficult or I don't like, such as the sit to stands and leg presses. One highlight was being able to run down the hall at the end of my classes. The trainers were always willing to support and encourage me during challenging workouts. The Power program has helped give me strength, coordination, and improve my daily life. For example, I have much more stamina to ice skate, ride my bike with my son. Just this past summer, we rode all the way from Grays Road to the Lethbridge, a 10-kilometer ride. The Power Study and Advisory Group, I learned I'm not alone. During the monthly Zoom calls, we would share our stories and experiences with stroke recovery. Everyone had a chance to speak and feel included. This makes us feel important because our thoughts and opinions matter. We would give advice, talk about different stroke recovery groups, and support each other. With our permission, our discussions are included in research papers so others can learn from our journey. I look forward to these Zoom calls because I feel like I'm making positive contributions that may help others and could impact future stroke victims and their recovery. Developing this community has increased my confidence in my physical abilities and led to better mental health. I look forward to the next session of Power program starting and setting new goals in collaboration with the trainers. Thank you.
Thanks so much, Carolyn. We're so thankful for you. And for some context, Carolyn is staying on as a partner for our next CIHR funded trial, which is really great. We're really excited for it. So thank you again, Carolyn. And that's all we have for you today.
Kenny and Carolyn, thank you so much, first off, but it's a little bit of a pre-thank you because we are going to move into our collaborative conversations, but I do want to, because we're at 12:52, we do have some time for questions, and I know that there's been some questions posted in the chat, but Carolyn, it's certainly, I understand, well, not I understand, I guess that's not even right, but for you to share your journey in this way helps us consider how complicated, right, people's lives are and how important it is that we consider best research, right, which is, part of it, but also that idea of understanding personal context. So I really appreciate you sharing that, including how hard the sit to stands are, which is something we can all resonate with a little bit. Yeah, so all of that to say, we do have some questions, and of course, people are complimenting in the chat. I know it's hard by Zoom to feel when we're in a room, right? How grateful and thankful we are to both of you for putting together this presentation, Kenny. And it's really complex, right? To do something when you didn't have any guideposts. Again, I haven't said any questions, but what I want to make sure is just to check here if there's some questions. And let me just take a look here because I know there was people interested in the links. And then, Jeanette, I'm just going to come back to you to see if your question ended up being addressed, because sometimes that happens when we post a question early, Kenny, right? At 12:22, Jeanette kindly, asked about how were patient partners involved in the data analysis. And Jeanette, I'll just come back to you if you're here, whether you could just let us know by unmuting if the question's been addressed or whether you'd like to know a little bit more. Please go ahead. I see you unmuted. That's awesome.
Okay, it has not been addressed. I am a patient partner in several research projects, and I have actually done a lot of evaluation, which is very much like system reviews and the data analysis. I do not have a affiliation with any institution, and as such, not able to, not permitted to access the data or the searches that you do. How do you get around that? Were your patient partners actually analyzing the data? Were they working from the code book? I have taken courses, so I do know how it works. I just can't do it. And it is very frustrating. I have a small grant for a patient-led rapid review myself. I will be the team lead, and I can't get my hands on any data, and it is really frustrating. Thanks.
Jeanette, sorry, Jeanette. Thanks for unmuting, and thanks for sharing. And not to speak for Kenny, but Kenny's going to respond, I think. But this idea of even in many areas, we actually don't have sort of what I was saying, a map. And maybe this is the beginning, right, Kenny? It's by no means the only way, but it's really great that it's been documented. Let's just say that. So Kenny, maybe you can respond to Jeanette. I know there was some other questions in there in terms of how you helped make sure the patient partners had the information that they needed, right? Because she's absolutely right. Accessing, as much as we like Google, there's still paywalls and different things that come up. Okay, back to you, Kenny. Jeez.
Yeah, thanks. Thank you so much for your question. I agree. There's sometimes some red tape from some institutions with regards to data. And I'll just be clear with what we meant by data analysis. It wasn't necessarily that we had our partners, running the analysis or doing the meta-analysis or what have you. But what we meant by this is we provided an opportunity for our partners to have the data if that was of interest to them, to access the papers, because I know in the community, sometimes they're really not easily accessible, whereas from a university, it is available. So we provided that opportunity, but also what we meant by analysis was that ranking or rating of the outcomes. It had a really key influence on our paper because we ranked the order of which we presented our results according to how important they were to people with lived experience. And so to answer your question, it wasn't necessarily that they were sifting through the data. Although this data actually is available, so we could let them have the data, but it wasn't really of interest to this group. So we allowed them to look through the papers if they were of interest, but yeah, not actually analyzing the numbers and whatnot. Yeah,
and I know, Kenny, sometimes for us to be able to share papers, right, for an educational purpose or this idea, right? Like there is sometimes Creative Commons that can share, share information and share papers, but certainly when you're accessing, I'm going to call it the raw paper, maybe not the raw data, it's still hard to understand, right? Kenny, Kenny's been in school a long time to understand that, right? So that's the hard part here. And then we expect everyday people to understand research. But there's another question here, and I know we're at 12:57 and we're trying to stay on time here, but there was a question about the financial implications considered in different provinces. Kenny, and I forget who asked that. Allison kindly forwarded this to me, so I just have to scroll back here, but I don't know if that person wants to speak a little bit more, but Kenny, maybe you can, Maria, excuse me, Maria has put up her hand. Go ahead, Maria.
I asked that question. I'm in Ontario. Oh, by the way, I'm sorry, Caroline, thank you so much for sharing your story. I am myself a survivor, so I appreciate the path. Thank you so much for sharing it with us. By the way, Kenny, thank you so much. You are definitely a researcher. I'm a patient partner with the Ottawa Hospital, and I had 2 aneurysms and a stroke. I am one of the lucky ones. I had amazing medical care. But my life after I left the hospital, after spending 3 months in the hospital, it's coming out of my pocket. So I would love to find out what different provinces are doing, because it is very, very expensive. And I am a retired person. I am eating my retirement kitty, which is fine. I worked 40 years. I have some kitty, but I find it a little bit disturbing that I supported the system all of those 45 years that I worked, and now it's not there for me. Or people like me, and not just me personally, people like me. So I am wondering if when we're doing that research, which is what I brought up at my own research group at the hospital, are we considering how much this is going to cost us, or who is going to provide us with the financial support And I'm not talking about having my manicure, my pedicure done. I'm talking about actual help. And I'm not expecting a house cleaner or anything like that. I want to have exercise classes provided for me because I will always need exercise classes. I will end up in a wheelchair if I am not doing exercise. So I will end up in a wheelchair, and that will be horrible because I'm a very active person. So, and I would like to continue my life, period. I am a healthy, other than that, I am a healthy human being. Anyways, that's my
Yes.
question. Sorry about that.
Yeah. No, thank you, Maria, and thanks for yeah, thanks for following up with that. I really appreciate it while I had my little coughing fit there. But yeah, it's a question, right, Kenny, in terms of yeah, how does the system support people, let alone, right? Like here we are trying to do research, and I think it's something we may, Maria, have to take into our small groups here. But Kenny, I don't know if you have a comment briefly.
Yeah, just a quick comment. I think while we didn't look at the financial implications in this paper, because they don't often talk about it in the papers, I think our first step was proving that strength training works. That was a really big misconception was in the stroke literature. People didn't know whether strength training actually has an impact. And so by showing that it impacts people with lived experience and their outcomes that are important to them, we can help push for these freely available exercise programs in the future. I think that's definitely a first step that we did here. So thanks for your question, Maria.
Yeah. Oh, thumbs up. Awesome. We love thumbs up. On our way out to our collaborative conversation. So I don't know if Karina, you can put up, I know Subhash, you got a question, but we actually need to move to the collaborative conversation. So maybe you can bring that. I'm really sorry to your group, and then we'll come back together. So if you're able to stay, again, thank you, Carolyn and Kenny. And I think Carolyn's going to try to stay for the collaborative conversation part. But again, it's an opportunity for trainees, research partners, and community members to come together. So yeah, how do we, we can have this conversation in terms of how do we make sure that strength training is available, I'm going to say, to every Canadian, Maria, let alone if you've had a stroke, which also takes another specialized area of expertise, right? In terms of understanding that. Okay, so I think Sue is going to work the magic here, and Allison to put us into our Zoom rooms. Yeah, and of course we thank our funders. So here we go. You have it on your screen. You get to press that and off we go into our Zoom rooms. Thanks very much, everybody.